Fasting is something I'm often asked about. Should we fast? Do we fast? And if we do fast, how long do we fast neonates and pediatric patients for? In my opinion, fasting is generally undesirable. I think you run a real risk of exacerbating dehydration and hypoglycemia. And sort of my rule in a pediatric patient who requires anesthesia, and I'm talking a pediatric patient here, not a neonate. A neonate, I really wouldn't withhold any food or water. And most of the neonates would be nursing or being bottle nursed, and so I wouldn't withhold anything until maybe an hour before the procedure. But my guideline would be about 1 to 2 hours liquids and 4 to 6 hours for solid food in the sort of pediatrics patients, so anything over 12 to 16 weeks of age. Again, exceptions that I may consider is any patient with delayed gastric emptying, megaesophagus, maybe a cleft palate patient, and certainly I'd be paying attention to glucose levels. And interestingly, our fasting guidelines that we've historically recommended may be excessively long for what is actually really required, and sometimes fasting may actually increase, or inappropriate fasting may lead to an increase in the risk of regurgitation or aspiration, and so they're being reevaluated, and we may see that our recommendations for fasting, even in our normal patients, may change in the not too distant future. As far as our anesthetic plan goes, my general plan is to use my doses conservatively, try and choose drugs that have minimal cardiopulmonary side effects and that are reversible, and then I don't have to worry as much about the ability of the patient to metabolize and excrete these drugs. And also to keep in mind that there's many pharmacokinetic and pharmacodynamic alterations, and we're going to talk a little bit about those. Another thing I like to do is try and minimize the anesthesia time. Having said that, I'm not going to rush a surgical procedure and have something done inappropriate just to reduce anesthesia time. I've had many neonatal and pediatric patients who've been anesthetized for upwards of 4 and 6 hours even. So it can be done for sure. It's just requires a lot of intensive monitoring and moment-to-moment adjustments and various things. Definitely I use active rewarming on these guys because they just don't warm up very well. So things like bear huggers and hot water blankets work well to get these guys warm. So we talk a little bit about their increased insensitivity to drugs, and there's several reasons for this. One is that they tend to have a very centralized circulating plasma volume, and basically what this means is that the blood is very circulated or centrally circulating, and a lot of it's not going necessarily to the periphery where drugs can be distributed and so forth. And so what we often see in these guys, in addition to the fact that they also have a reduction in functional residual capacity, is we see a lot faster onset and plane changes with inhalant anesthetics. And this is probably why inhalant anesthetics have been used not uncommonly to induce anesthesia in neonatal and pediatric patients. And we'll talk a little bit about that. Increased permeability of the blood-brain barrier may be another reason for increased sensitivity to drugs, although this hasn't really been delineated as clearly as perhaps some of the other reasons. Another thing that has been suggested, but again, I can't really be convinced that this is that clinically significant, but the neonatal sort of relative hypoalbuminemia, when you use your sort of standard dose of drug, some of the drug is going to be bound and some will be unbound, and that unbound portion of the drug is the portion of the drug that can interact with your receptors. And so if you have a patient you give a standard dose of the drug to who has very low albumin concentration in the body, that patient may actually have a lot more free drug floating about, which could lead to increased effects. I can't say I've appreciated this clinically. They do have a lower percentage of body fat, so they may not be able to redistribute drugs as readily as some other patients, or they don't have as many places to redistribute the drugs to. Another thing I should point out here is that a lot of the drugs are redistributed initially to muscle, and again, a lot of these pediatric patients wouldn't have the same relative amount of muscle in their body to redistribute to either, so they don't tend to redistribute drugs as much. So the clinical significance of all this is hard to always predict, but what's great about the anesthetic drugs, and especially about the way we recommend people use anesthetic drugs, is to titrate to effect. Titrate, versus just giving a big whacking IV bolus to the patient. Now, having said that there's increased sensitivity, there may also be decreased sensitivity to drugs. And this isn't really something that comes into play with a lot of our anesthetic drugs, but certainly for some antibiotics, when we need to reach therapeutic plasma drug concentrations, by not giving a suitable dose and assuming that the patient is going to be more sensitive to the drug, they often do have a larger volume of distribution of some drugs, especially the water-soluble type drugs. And so in some of these patients, if you give the same dose that you would give to an adult on a mg/kg basis, the actual amount of volume that drug is going to distribute into may be higher in the neonate, which will actually reduce your plasma drug concentration. So this may partially offset the increased sensitivity to drugs. Again, this isn't something I think I appreciate a lot from the anesthetic point of view, but if I were looking at antibiotics and so forth, this might be something that becomes more significant. Could also be significant in the analgesics, although I think most of the times our analgesics, when we administer them at clinical doses, we're probably well above the minimum plasma drug concentration for effectiveness. So what do I use? What drugs do I use? This is always the question. This is usually the sort of thing people want when they talk to me is it's kind of, well, just tell me about the drugs. And really the drugs are probably the easiest part about choosing an anesthetic protocol and performing the anesthetic on any of these patients, or any patient for that matter. Selecting the drugs is often not as important, the drugs, as it is the way that we use them. Now, having said that, with neonates, we can make some very intelligent decisions about the drugs we use. We can also make some very less appropriate decisions about the drugs we use. Ultimately, I'll always argue that we need to individualize our drug selection to the patient. In general, what I'm using most times in these guys is an opioid plus or minus some kinds of benzodiazepine as a pre-medication. Oftentimes, opioids alone work well and provide nice sedation in these guys. And a benzodiazepine, although in an older patient can sometimes cause a little bit of excitement, will also work quite well in these guys. So that tends to be my foundation of my pre-med. I don't use a lot of anticholinergics in my pre-meds routinely, but I will use them if it's appropriate. As far as acepromazine goes, it does have prolonged and profound effects, and hence I try to avoid it. You do get some hypotension, and you can have hypothermia being exaggerated when using acepromazine. Alpha-2 agonists, I've already mentioned that these drugs do cause very significant cardiovascular effects, and therefore they're often avoided. So again, opioids and benzodiazepines tend to be what I use. As far as induction goes, there's various options. I'll talk a little bit about masking with an inhalant. I think it's still something that's done relatively commonly and with success. I will say I personally don't mask down very many patients. In fact, I can't think of the last time I really masked down a patient. And the biggest reasons for that, and the reasons I tend not to mask down patients, well, first let me talk about the advantages, I suppose, as to why we would mask down a patient, and I think most people would be very familiar with these. One, it doesn't require an IV access, and sometimes in these little wiggly puppies, it can be hard, or a kitten, to get an IV access. The inhalants require minimal metabolism, so it's very predictable, their recovery. And really, most neonates and pediatric patients really tolerate this technique well. They don't really go through a lot of excitement. And in particular, if you use a drug like sevoflurane or desflurane, it's amazing how quickly these patients mask down and how quickly they wake up. I do actually remember masking down some puppies, a litter with prolapsing rectums, probably a couple of years ago, where I used desflurane. These were probably puppies who were maybe 3 or 4 days old, and they had prolapsing rectums, and this worked great for those patients. I mean, it was literally a 2-minute procedure to push them back in, put in a purse string, and so to put in an IV catheter and so forth seemed a little bit excessive. So there are certain instances where masking will be very, very useful. Having said that, we have to keep in mind some of the disadvantages. There is considerable cardiopulmonary depression associated with this technique. If you're just masking them down to a very light plane of anesthesia to do a very minor manipulation with maybe a little bit of local anesthetic adjunct, you may not get that much cardiovascular depression or cardiopulmonary depression, but if you mask them down to a level that allows intubation, these patients are fairly cardiopulmonary depressed. The other problem, or the other thing I see with giving or masking patients down is that I have less control over the administration of the drugs. I'm reliant on the patient to breathe in order to take the drug in and to get rid of the drug. And sometimes, depending upon what the patient is like or how cooperative they are, they may have a very slow induction. And you can also see some emergent delirium or induction delirium, which can be a problem. So I tend not to mask down these patients, but a lot of it would have to do with the caseload that I tend to see. Most of the patients that I tend to see are undergoing a rather major surgical procedure where masking just really wouldn't be that appropriate, because I'd ultimately still need an IV access in these patients, and they're going to be anesthetized for a long period of time. So it really doesn't make a lot of sense for me to try and mask a patient with, under those certain circumstances. So really, intravenous is what I prefer in most of my patients, especially in those prone to dyspnea or hypoxia, or at risk of regurgitation and vomiting. Now, some people may say, well, what about in a dyspneic or hypoxic patient? Why not mask them down because you're giving them 100% O2? Well, because in the dyspneic or the hypoxic patient, they may not take in the anesthetic as predictably as I would like, and it may be a much slower induction, and they may have some respiratory depression that could then lead them to become hypoxic, even if they are on 100% oxygen, and I don't have a tube in yet to sort of control things. So I like to get control of the airway very quickly, put a tube in, and then I have complete control over that patient's delivery of inhalant as well as oxygen to the patient. As far as catheters go, again, my patient population, I tend to have catheters in everybody because these patients are under anesthesia for a much longer period of time, and I use it to obviously administer the fluids and for drug support. It does allow that rapid induction and intubation. One thing about catheters that I think sometimes we forget about is that yes, it can hurt, but let's put on a little EMLA cream. This is readily available. You put it on, I say 30 minutes prior. You can probably get away with putting this stuff on the skin 5 minutes prior and still get some effect from it. But it's amazing how well it works. These guys are hard to hold at the best of times. So you just put a little bit of EMLA cream over your catheterization site after it's been clipped. And these patients won't even feel the catheter going in. And so, this to me is something that if you don't have it in your clinic right now, you probably want to have a tube sitting around just for this type of thing. Because even in the older dog who keeps pulling their leg back, every time you try and get that catheter and you just touch the skin and they pull their leg back, yet they're adequately sedated and you feel like, holy mackerel, what am I going to do? Putting a little EMLA cream on can really help. As far as catheter sites, obviously cephalic, the femoral. Occasionally we'll use the jugular in really small patients when we can't get a peripheral catheter in. And intraosseous is an option in really small and dehydrated patients, but I don't think I could probably count on 2 fingers the number of times that I've actually used that route, but it is available certainly. As far as my intravenous opioids and the options and what I tend to look at using, certainly there's propofol with or without a benzodiazepine. It has very predictable extrahepatic sites of metabolism, which makes this drug very useful in the pediatric or neonatal patient. Ketamine and benzodiazepine has nice cardiovascular stability associated with the drug. It does tend to increase sympathetic tone, but certainly ketamine and benzodiazepines are highly metabolized drugs, both of them, and it may not be our ideal choice. Thiopentol and benzodiazepines, again, plus or minus. And you can see I use plus or minus quite a bit because I feel like there's a lot of variability in the individual patient. Thiopentol is probably the one I would very rarely, if ever, use in my pediatric patients. And it's not to say it can't be used. And again, I'll stress the point that there's really very few pure contraindications to any of these drugs. It's the way that we use them. But if I were to use thiopentol, I would definitely expect to have somewhat of a hangover. The patient may be sedated a lot longer than what I would get with my propofol. And, if I'm comfortable with that and my owners are comfortable with that, it's probably not a completely inappropriate protocol to use. Having said that, I think, in the neonatal patient, if you have propofol available, it would be my drug of choice in these guys, just because it has very predictable induction characteristics and it's eliminated very predictably.